hearing this WHO headquarters prospect. Please join me to welcome Dr. Valerie McCormick, the Environment and Lifestyle and Epidemiology Branch, International Agency for Research on Cancer, IARC. Please.
Good morning all, Sabah al-Khair. It's my pleasure to be here on behalf of the International Agency for Research on Cancer and on behalf of our director, Elizabeth Weiderpass. I'd like to express special thanks to Hisham El-Ghazali for the invitation and for organizing this great conference. I'll talk on behalf of Partha Basu and myself, and I'm very pleased to go straight after Mary Nyangasi at WHO, and we're working with her closely on the Global Breast Cancer Initiative. Just the outline, a little context, and impressions of a site visit to the Presidential Initiative on Women's Health, and then the joint priorities we have agreed with our Egyptian colleagues. So the context of our collaboration with Egypt is that Egypt joined IARC in the middle of last year. And we're really privileged to have Egypt as a middle-income country in IARC alongside India, Morocco, and Iran. And we're really pleased to be able to learn from Egypt, from a large country within Africa and within the Emro region. And there's been a huge, impressive investment into cancer control, not just for breast, but for bladder cancer in the past, for liver cancer. And the scale, the political will, and the commitment, and how it's impacted on saved lives is really impressive, and really happy to have this collaboration and to learn from that and set an example to other countries. So for breast specifically, what are we talking about in Egypt? We're talking about approximately up to 30,000, maybe higher, women diagnosed with the disease per year, and 10,000 deaths. Obviously, these are estimates, not precise numbers, but a large burden. So Partha and myself had really a privilege of visiting the Presidential Initiative for Women's Health 3 months ago. Not only to enjoy incredible Egyptian hospitality, but really to see the program in operation from the grassroots level all the way through to specialized treatment centers. So we started our journey in Sohag, down a few hundred kilometers south down the Nile, and saw really women coming into primary healthcare programs, being given breast health education, seeing a setting where the CB is conducted, to a local cancer treatment hospital, to specialized breast cancer treatment hospitals here in Cairo. It's an incredible program, more than just a screening program, but really, as Mary said, it's an index cancer, so it's really strengthened patient referral pathways, treatment guidelines, and care. Very impressed by the comprehensive program, not just restricted to a narrow screening age, but educating the next generation of women. So health literacy for underage 35s who don't have a current high risk of breast cancer, but there'll be future generation of patients. So they're going to be empowered with the knowledge to present earlier. And then for the women at high risk and 35 plus, the clinical breast examination at the start is a practical way forward. It's feasible. It's been rolled out across the country, and really the program's so impressive in the way it's thought right from the community level all the way to treatment and post-treatment to survivorship and quality life of women. The Egyptian example is a great example to learn from, so to see the health system strengthening from diagnosis, pathology, the patient navigation systems, as Mary was mentioning as well. And it's not just a single center. It's not a single example of a small center working, and there are many of those. It's a large-scale program, and it was implemented very rapidly, even despite COVID. So all of these achievements are pretty phenomenal. So at IARC, we're really privileged to be collaborating with Egypt on this and seeing how the program can be rolled out elsewhere. So what did we agree on? Oh yeah, the second thing that is incredible for the program is the foresight into invest into data collection. This is the data collection from the first entry point is harmonized across all the different health systems. It has great benefits for real-time follow-up to reduce delays in the patient journey, and it obviously provides us with immense research potential. And we saw in Cairo that in a single data system, you could know what's happening to all of the women followed through to their diagnosis and beyond. So the priorities we agreed and discussed were, first of all, to look at the overall global screening performance and enter that data into CanScreen 5, an initiative by Partha Basu and his team at IARC, where the screening performance can be compared, benchmarked across countries to see how well it's doing and to show others what can be done. The second priority is to look at the examples, what has happened here, the health system strengthening, look at how the diagnosis was improved, patient navigation was improved. As Mary said, measuring the GBCI, the Global Breast Cancer Initiative, KPIs is critical, so we hope to be able to measure them and monitor them and see where the gaps lie, where our priorities need to be made. We'd like to do some in-depth studies beyond these KPIs, looking at the breast cancer patterns of care, looking in detail at the whole breast cancer journey, really to identify the delays and which women are vulnerable to experiencing the delays or which parts of the country. And we have many examples from other parts of Africa where we've done these kind of studies already. Another priority is linking the diagnosed breast cancer patients to survival outcomes. So linking to vital registration systems, first of all, just vital status, but hopefully eventually cause-specific death. And this will empower us to do survival gap apportionment analysis. So how large are the survival gaps compared to maybe the best settings, and what are the drivers of those gaps? Is it late stage? Is it treatment incompletion? And we'll be able to model these. So that linkage to the survival is critical. And I just give you an example. I love this paper. It's in the British Medical Journal from 22 years of breast cancer patient mortality in England. They've been able to look at mortality rates of 500,000 women and look at how they've improved over time, look at the determinants of long-term deaths in the long term. And if you think about what can be done with the Egyptian data, this will all be possible. In 5 years' time, you'll have about over 120,000 women in that data system. Linking them to the mortality will be critical, and looking at the determinants of that patient mortality. In 10 years' time, you'll have 250,000 breast cancer patients. We also have some tools that we'd like to look at look for appropriate solutions to address the barriers. And in Partha's team, there's a nice online tool called the Intervenor, which will get stakeholders' views to improve the system. And then lastly, Women's Health Initiative is a real-life cohort. There's incredible data collected on the NCDs on the population of women being screened. So we'll be able to look at population triple fractions. So what are the drivers of high incidence rates? How can we prevent some of these breast cancers occurring in the first place, looking at the role of obesity and diabetes in particular in this context. And then finally, this incredible investment into the data means that instead of using high-risk scores from other settings, we might be able to optimize the screening program in the future to have an Egyptian-specific risk score that you use your own data to improve your screening algorithms. So I think I'm just over time, so it just leaves me to just express a huge thanks to the Women's Health Initiative and to Egypt for the investment, for the opportunity to collaborate, and to everything you've done here for women's health. Shukran.